Dr. Luke Evans.
Just welcome. Primary care. Can you set from the outset, briefly, what your perspective is of the landscape of GP services from the doctor's perspective and from the public's perspective?
First, if I may, Mr. Evans, what I would say is that I'm really proud of our GPs up and down the country, and I think that there was a lot of demand pre-pandemic, but of course, because of the pandemic, whatever demand they had before, you just multiplied considerably for all of them. And I think that what we've seen throughout the country, especially over the last 18 months, that GPs are really stepping up and doing what was needed of them and answering the call from the British public. And as the Secretary of State for Health, and I think I speak for all my ministers and certainly all of them in the department, I think as a nation we couldn't be more proud of our GPs and what they've done. If you think of the vaccination programme, for example, as they are doing now, right from the early days of the vaccination programme to the booster programme, right now how vital that is. It's GPs that are getting out there to some of the most vulnerable in the care homes, in those that are homebound, and making sure they get their vaccinations, including of course the flu vaccine now as well. It's hugely important. So nothing but praise for our fantastic GPs. In terms of looking ahead now and the challenges, we saw during the pandemic, we saw people stay away from healthcare in the normal way, including primary care. We were told to stay at home, so of course people weren't able to go to their GPs physically, let's say if that's how they normally had done it. And there was a requirement for there would only be a remote consultation because of the rules of the pandemic, and people understood that, and the GPs again rose to that challenge. As we are now moving more to normal, we're not quite there. The pandemic is, of course, it's still there. It's very important that we keep our defences up against it, and more people are coming back to see their GPs because perhaps they'd held back before. That demand is increasing, and GPs are getting record numbers of appointments. And it's important that those patients are, that they can be seen as quickly as possible, and that where those patients have a desire to be seen face to face, this has been an issue of debate recently. I think that choice should be respected as well.
There's a rub there, isn't there? And what's the correct percentage, do you think, between face to face and remote contact?
I don't think there's a right or wrong percentage. I think it's more about. So I wouldn't, in my mind, there's no target. As in, if we want to put some numbers on, just historic numbers, I think approximately pre-pandemic, around 80% of appointments were face-to-face appointments in primary care, and around now it's around 60%. I think last month it was around 60%. And so that's where we are today versus pre-pandemic. But for me, it's never been about it should be 80% or 70% or something. It's not about a number. It's about doing the right thing, and ultimately, I guess it's about choice for the patient. Where you have a patient that wants to be seen face-to-face. Perhaps the initial consultation might have been a remote, but they feel that they should be face-to-face. I think it's really important to try and meet that.
So I asked the same question to the CEO of the NHS, and she answered in exactly the same way. I guess the counter-argument and where the rub comes from where I sit is what's clinically appropriate and allows the NHS to do more versus the patient choice, because it might be completely clinically appropriate for the doctor to say, send in a photo if you've got a digital camera of your skin lesion to the doctor to make a decision for the doctor to decide if they need to see you. The patient may say, I want to be seen face-to-face for that to be assessed. That is the rub that is happening on the coalface. Where do you stand on how do we resolve that?
Well, ultimately, is to recognise that there is huge demand on primary care services. And where we stand is on the side of the patient and the GPs in helping the GPs what they love doing, which is seeing their patients. And that was the purpose of the recent sort of winter access package, I think we called it, is working with the GPs, listening to what they had to say, is to come forward with whether it's funding or other interventions that will help them do more of what they love doing, which is seeing their patients. That was the purpose of the package.
You brought up the access, and that leads me on to the next part, which is sort of productivity and the access. Much was made about league tables. Do you plan on going ahead with league tables for GPs?
We never plan having league tables. We never have. That's never come from the department. It's never come from the NHS. I think what that might be a reference to by some is that the GPs in their last contract, which I think was negotiated in 2019, that it included transparency, the need for more transparency that GPs rightly accepted, and being able to publish data at a practice level rather than at the sort of regional CCG level. And that is something that's we intend to go ahead with, which was agreed back in 2019. I think understandably a lot of that data collection was paused during the height of the pandemic, quite rightly so. But I don't know where this idea of league tables comes from. I think that
Will that data include the proportion of face-to-face appointments by practice?
I think it will, yeah.
And broadly speaking, the figures roughly used, 9% of the NHS budget goes towards general practice, of which they see about 90% of the population. Do you think that figure's right, given the pressure they're under?
I don't know, to be honest, at this point. I don't know. I think certainly what we need is, especially now in light of the lessons we've learned through this pandemic, is a transformative approach about how we deal with future health challenges, demand on healthcare, the waiting list, the electives backlog, mental health we just talked about, and I think that does mean a fresh look at how we see sort of how does primary care work with secondary care, work with community hospitals, work with people in the community, with midwives, and to take a fresh look at all that. And really? And I've started that process. So the leadership review, and as part of that is to look throughout the NHS and the care system, but especially focus on NHS, not just hospital leadership, but primary care leadership, community hospital leadership, and to look at where in some parts of the country there are different models of the relationship between primary and secondary care. For example, Wolverhampton, for example, parts of Wolverhampton have a specific model where I think that some of the GPs work directly for the NHS. So I think it's important to take a proper, fresh look at this in light of the level of demand, the changes in demand. But at the heart of it will again be, in primary care, will be our GPs. They do deserve a huge amount of support because they are facing unprecedented challenges, and it's my job to make sure that we are listening.
I'm really pleased you picked up on that, because I'm not going to go through the long term. My colleague's been through the long term plan, but in the short term, one of the things we saw in the pandemic was a revolution in the thinking that we could suddenly get rid of the red tape for whatever reason, and clinicians seem to have thinking space, and we've heard that from other witnesses in the last couple of sessions that we had. Is there a way you could foresee protecting thinking space for clinicians? Paid incentive through QOF, for example, where you could protect time for them to concentrate on the models of their local care. These revolutionary ways of enhancing the improvement in the NHS at the coalface seem a very sensible way, on the light of what you've put in the winter plan, access plan, about moving red tape of who's doing sick notes and things like that. Is there an emphasis in a plan to put that kind of practice in place? Because that will make a huge difference in the immediate effect. And how can the department capitalise on that?
Yeah, I mean, what we've announced in the winter access announcement, we're putting all that into place now. Some will move more quickly than others. So there's £250 million in the winter access fund. There's more use of the community, the pharmacy, the consultation service. There's some GPs, they came to us and said, our sort of telephone systems in terms of cloud computing and how the patient experiences when they call the practice, how we can change that. We're investing in that, and also the access improvement program as well. We've done all this, listening to GPs. If there's more we can do, I'm ready to try and do that. It's a really important partnership, and we'll continue to work with them.
My final question is about GP and workforce actually in primary care. Their wellness, their well-being. A lot of them are facing abuse. A lot of them are also facing burnout. Is there a programme the government could consider about how to look into simple measures that would support the welfare of the frontline services in primary care, be it time to think, places to speak to, the ability to use some of the funding for team building. All these kind of things could make a huge difference to the quality of the working life, which may encourage more members of staff to stay on and continue to contribute to the NHS.
The short answer is yes. I think there is more we could probably do to help with that. And I think it's important we look at that. And can I just say something, because you rightly mentioned it, that sadly we have seen abuse of GPs and actually other healthcare workers and nurses, for example, as well. And just sticking to GPs for a sec, I think there will never, ever be an excuse to have any kind of abusive behaviour. We've seen horrific abuse, actually, of GPs. I won't mention the practice, but we saw real serious injuries, and someone could have lost their life in terms of the attacks that we've seen. I will never, ever, this will never tolerate any kind of abuse to any kind of healthcare worker, ever. Zero tolerance. And the package I referred to earlier, one of the things I insisted putting in there, just to make sure that we were there and ensuring that we want to help in every way we can, was, I think, £5 million of funding for any kind of security need for any practice, be it CCTV, panic buttons, anything, if a practice thought that they needed it. If that money wasn't enough, we will certainly look to add to that and support our fantastic GPs in every way we can. We want them to feel absolutely confident in the work that they do, the incredible work that they do, and we will always support them. And you've just mentioned some